over to Dr. Keats. 1 second, Dr. Keats.
Sure.
Great. All right, we are now recording. Dr. Keats, would you like to start the webinar, please?
Sure. First, I just wanted to say welcome to everyone who phoned in, who logged in. Appreciate the opportunity to spend some time with you this evening. As Kate said, I'm a psychiatrist. I practiced actually in Virginia for many years. Been with Anthem for 3 years as the behavioral health medical director for Anthem Healthkeepers Plus. So my hope this evening is that I'm able to provide you with some education about psychiatric medications and their use in children, foster care children in particular. But let me also say that I don't know much about what you guys do as foster care parents and the challenges you face. So I hope to learn from you as well. Just a bit of brief background. As you probably know and experience, day to day, the rates of behavioral health disorders in foster care populations approach 80%. And foster care kids are 4 times more likely to be prescribed psychiatric drugs than other children of the same sex and age. So, as you probably know, there's been a lot of focus at the state level, at the federal level, through organizations of, physicians to try to improve the prescribing, the appropriate prescribing of psychiatric drugs to children in general, to foster care children in particular. And part of what I hope to do tonight is to empower you with knowledge and especially the right questions to ask your foster child's physician or prescriber to make sure they're getting, the most appropriate and effective treatment possible. We should have, I've got 20 slides, and so we should have plenty of time for questions and comments and suggestions, and I really encourage that. And as you heard, both Jamie and Ina, their exclusive focus is working with foster care children who are our members and their families, social service organizations, and so on. So they're a great resource to have as well. First, just sort of a word from our sponsor. I wanted to tell you a little bit about Anthem and Anthem Healthkeepers Plus. As you know, Anthem is a national health insurance company. Anthem's purpose statement is, together we are transforming healthcare with trusted and caring solutions, and the company's vision is to be America's valued health partner. 1 in 8 Americans are actually insured by Anthem, some form of Anthem. It says 39.8 here. Actually, we were told by our CEO last week we've passed 40 million members, which is a privilege to serve that many people. Here in Virginia, Anthem Healthkeepers Plus is currently the largest Medicaid managed care organization, actually managed Medicaid in general. We go all the way back to 1996. We have nearly 300,000 Medicaid and famous members, and we're all across the state. 95 counties, 38 independent cities across Virginia. We are also, and more relevant to tonight's presentation, the largest provider of Medicaid for foster care and adoption assistance in Virginia. And one last slide about Anthem Healthkeepers Plus. The programs we offer include Medicaid, FAMAS Moms, and coming soon to a neighborhood near you, it's actually Medicaid's new product, CCC Plus, which is a integrated behavioral, medical, and long-term supports and services product. NCQA has given Anthem Healthkeepers Plus a commendable status, which we're very pleased with. Okay, on to the topic at hand. So you may have not heard this term psychotropic medications. Don't let it throw you. You can use the word psychiatric medications. It's really the same thing. I want to start off by saying, and it's probably self-evident, but psychiatric medications are used to treat a mental health issue or state. There are many psychiatric medications that can be placed into different categories because of the main mental health issue they're designed to treat. So the main categories of psychiatric medications include antipsychotics, antidepressants, anti-anxiety medications, mood stabilizers, and stimulants. But let me just say that, a lot of medications, psychiatric medications, cut across these classes. So, for example, a very well-known psychiatric medication, Abilify, is classified as an antipsychotic, but it also can be used as a mood stabilizer. And in some instances, it can also be used to help treat depression. So just to make life a little more interesting, even though one of these drugs may fall primarily into one of these categories, it may well have multiple purposes or categories that it's in. I haven't listed every single antipsychotic here. I believe there are upwards of 20 now. But antipsychotic drugs are used to handle health issues that affect the mind and in which there's been some loss of contact with reality. These health issues usually include delusions, which are false fixed beliefs, or hallucinations, which are hearing or seeing things that aren't really there. And I would also add, antipsychotics also treat what's called a thought disorder, which is a profound impact on the ability that people have to put their ideas together in a logical, coherent fashion. The first antipsychotic on the market from about 1952 was Thorazine or chlorpromazine. As you know, every medication has a brand name and a generic name. We're using generic names in this presentation, but I'll tell you what their brand names are as well. So haloperidol is Haldol, risperidone, Risperdal, Zyprexa, Olanzapine, Seroquel, Geodon, Abilify, or some of the more commonly prescribed antipsychotics. Antidepressants, on the other hand, are drugs that are most often used to treat depression. However, they can also be used for other health issues. I would say primarily anxiety. Some of them also are used to treat chronic pain, insomnia, and some other disorders. These include things like fluoxetine, Prozac, citalopram, Celexa, sertraline, Zoloft, paroxetine, Paxil. The next one is Lexapro. This is just a partial list to give you a flavor. The other thing I would say, and I'll repeat this, it's really important to know about antidepressants, is that every single one of them takes time to work, which is very different than most other drugs. I mean, if you have a headache and you take Motrin, you expect to feel better within an hour. Or you take an antibiotic, you expect it to work in a couple of days. Antidepressants take weeks to work, usually a minimum of 2 to 3 weeks if they're going to be effective, which is really important to know because people get discouraged quickly, especially if they're depressed, and might give up on the medication early and stop it prematurely. We'll talk more about that when we get to some of the other parts of the presentation. Anti-anxiety medicines help reduce symptoms of anxiety like panic attacks or extreme fear and worry. The most common ones are benzodiazepines. You may have heard that term. Examples are clonazepam, Klonopin, alprazolam, Xanax, lorazepam, Ativan. Partial list, not a complete list. There are actually some other anti-anxiety medicines that fall outside of this class of benzos. Buspar, you may have heard of that, is an example. Works with anxiety, but works a different way. Once again, my intent not to make you guys experts in psychopharmacology, but just to kind of give you the basics and then certainly open up the talk to questions later on. Mood stabilizers are mostly used to treat bipolar disorder, which is also was known earlier, it's still known as manic depressive illness. mood swings tied to other mental disorders, and in some cases to boost the effect of other drugs used to treat depression. Lithium is probably it's definitely the oldest and best studied mood stabilizer around, discovered in 1948 as a treatment for manic depressive illness. But other common ones that are used include Depakote, which is also called valproate, or Tegretol. The generic is carbamazepine. Also, there are quite a few antipsychotics. This is what the confusion I was talking about earlier, where a drug might be in several different classes, are also approved to treat mood problems and like mood elevation in manic depressive illness. An example would be Zyprexa, which has both an indication to treat serious chronic psychiatric illness like schizophrenia and also mood elevation in manic depressive illness. Stimulants, because they're so widely prescribed, are maybe most familiar to the folks in the audience. I don't know. Stimulant drugs are often used to treat children, adolescents, or adults with ADHD. And examples include, and they're something like, it's very hard to keep up with them because it seems like a couple of new ones come out every year, but they really all boil down to either methylphenidate, Ritalin, amphetamine, Adderall, dextroamphetamine. These are variations on the theme of stimulants, but they're much similar, more similar than they are different. Also, and it's not on the slide, I apologize, there's another class of drugs, of which Intunib is one, clonidine is another, that are used also to treat some of the more hyperactive or impulsive symptoms of ADHD. And they're not stimulants, but they are ADHD drugs. That was an extremely fast clip through the world of psychiatric drugs, partly because I want to spend most of the rest of the formal presentation on talking about some questions, some guidance, some things to expect when you take your foster child for an evaluation, to make sure that they are getting a thorough evaluation and follow-up. Doctors are often very busy these days and may not always ask you if you understand why they are recommending what they recommend. Also, a doctor's office can feel like a bit of a strange or intimidating place. And we've all at times felt like maybe we shouldn't ask questions because we'll appear ignorant or out of place. My advice to you, please don't let these feelings stop you from getting answers to the things you need to know. You should leave the doctor's office with a comfortable understanding of why they recommended the treatments they do and the confidence that they have conducted an in-depth evaluation. The next several slides are intended to help you get there and feel confident you've made sure your foster child is getting good care. So things your doctor should, and by the way, I may have skipped something here on the last slide. So, yeah, I did. You'll notice there's a lot of overlap between these slides, but I think it's okay to repeat some of this because most of these things are pretty important. So things to talk about at your foster child's first doctor's visit. Obviously, the child's complete health history if you have it. And I understand from talking to Kate, that's often a challenge because you may have just, I don't know if the word is received, but, taken over the care of your foster child the day before. And you don't have the history. And one of the things I think it might be worth talking about with Ina and Jamie is some ways sometimes we may be able to help with, because we often have a more complete record of one of our members' history than any individual might have. The rates of trauma in foster care kids are huge. There's something like 5 or 6 times the rate of PTSD in foster care children than in other children. So if you know anything about it, that's very important to communicate. Also, depending on how long, I guess, you've lived with your foster child, any current symptoms, and especially if you, have some kind of a record, a list of the symptoms. Now we're really talking at this point, of course, about behavioral symptoms, not physical ones. The doctor would like to know, if possible, when the symptoms started, how often they occur, what tends to make them better or worse. In other words, sort of like doctors always ask about pain. What makes the pain worse? What makes it better? Those give clues as to what might be going on and what some of the treatments might be. And particularly any traumatic events that happened right before the symptoms started or got worse. I think you'll find most of these things are common sense, but it's still, I think, worth going over them. And things that your doctor should do before treating your foster child for a mental health problem. Carefully go over the child's health history if their records are available. If you have the records, I would certainly expect the doctor, either if you can get the records to the doctor beforehand, so the doctor could potentially look at them before they see your child. But even if, assuming they're not 4 inches thick, like a phone book, expect the doctor to at least skim through it while they're there or look at it after you leave. Do a psychosocial assessment, which is an evaluation of a person's social status and ability to function within the community. A mental exam. We could talk a little bit more if you want about what would be included there, a physical exam. And to make at least a preliminary diagnosis. There are a lot of conditions that cannot be diagnosed the first time around. Sometimes the doctor needs to run tests, get the test results back. Sometimes, like in the case of diagnosing ADHD, they may give you forms to fill out or for the teacher to fill out and bring back. So I don't want to give you the impression the doctor should say, I know exactly what's going on and it's whatever the first time around, but they should at least have some theories about what the problem might be and share that with you. I think, and we'll hear this theme again, before they pull out the prescription pad, you would want them to consider non-medical, meaning really non-pharmaceutical approaches like counseling, what school-based services are available for your foster child, and also to potentially offer therapy or counseling as part of the treatment plan. That's a thing you'll hear again and again. And we can talk more about that in the Q&A. Things your doctor should tell you before you give now I borrowed these slides, so it used the phrase, your written permission for treatment. Actually, I wanted to ask you, Kate, are you on?
Yes, I'm here. I'm muted, so I could.
It's okay.
Okay.
In the state of Virginia, is written permission required before a child begins medical treatment, a foster care child?
I do not know about that. The social worker, the child's worker has to approve that the child's going for treatment. But if you're talking about permission for them to receive the treatment, we have that program in Illinois, but I don't know about that here. I'm sorry. I should know that, but I don't know.
I don't want to mislead the audience that I think that is necessary if it's not required.
Right. The foster parent can't give the permission for it. I can tell you that. That permission has to come from the agency with custody.
Okay. Well, I don't have a secret inside track on whether it should be written or not. It's just the way the slide was framed. So I just wanted to make that clear. So, but, whether the permission is written or not, you're still going to say, yes. Well, actually, let me ask you this as well, Kate, or Ina, or Jamie. So if the doctor says, I think your child is suffering from this and that, and I'm going to recommend this particular treatment, and here's a prescription. At that point, does the foster care parent have the authority to say, on behalf of my foster child, I give permission?
No, they cannot.
Okay.
That has to be done by the agency with custody.
Okay, all right. So
They can give permission if it's a life-threatening issue and they go to the hospital and a leg has been cut off or something like that. I mean, some life-threatening issue, they can say go ahead and get started, but that really is the role of the social worker and the agency that has custody.
So like I said to everybody in the beginning, I fully anticipated to learn from you guys as much as you learned from me. So let me ask another question. So would the social worker typically be present at like the initial doctor's visit?
No.
So then the doctor, interacts with the foster parents, with the child.
Mm-hmm.
And then what is the role of the foster parents in relaying the information back to the social worker, or is that done directly by the doctor?
Well, the foster parent would have material that they get from the doctor about what the doctor is suggesting, and then the worker is the one who would approve that.
Would it still be appropriate, though, to help guide through this presentation the foster parents about what sort of questions they should be asking?
Absolutely, because the foster parent's going to be the one who's going to be working with the worker to say, well, this is what they said and this is what I think is going on. And then Medicaid is basically the one that approves whether or not they're going to get certain treatments or certain medications.
Sure, and that's actually something I often get involved in.
That's right.
Okay.
And at the end of this presentation, we'll let some of the foster parents chime in about how it actually works in reality for them.
Okay, I'd be very interested in knowing that and helping where I can and learning where I can't. So obviously, like we're saying, the doctor should be able to tell you, if not in the first visit, in the vast majority instances by the second or third, what they believe is going on. The child's diagnosis, the results of any lab tests, possible benefits and risks of treatment, possible side effects of the medicine, including, even if it's not a common side effect, but it's possibly severe, such as seizures or life-threatening allergic reactions. There are several psychiatric drugs that can lower the risk or increase the risk, lower the seizure threshold for seizures. And something that often doesn't get discussed very often, what's the risk of no treatment? In other words, suppose my foster child doesn't take this medicine or doesn't take any medicine. What's the risk of that? Often doctors are kind of biased towards action. We doctors tend to want to do something. And sometimes pulling out the prescription pad is seen as a very direct way of doing something. But I think it's always worth asking, well, what happens if they don't take this medicine, but maybe they just got counseling? And the answer might be, well, we could try that. And if the counseling doesn't seem to be helping, then they could take the medicine. Or the doctor might say they work better together, the counseling and the medicine. Or they might say, given how severe this disorder is, I think if your child doesn't take this medicine, it could get worse. But it's very hard to know what the benefits and risks of treatment are without talking about the risks of no treatment. So that's something I would suggest you keep in mind. If that's not brought up, if the doctor just springs into action, it's worth asking that question sometimes. And if your doctor does prescribe a psychiatric medication, and I would say to you, by the way, if I had only one slide to leave with you, it would be this one. Many of the problems with overprescribing psychiatric drugs to foster kids could be avoided if doctors stuck to these principles. The problem is, the more drugs that get added to the mix, let's say it's not unusual, I hear of cases where a child is on 2 antipsychotics, a stimulant, one of these other ADHD drugs in tuna, a mood stabilizer, maybe an antidepressant. When you get to that point, it becomes harder and harder to tell what's going on and whether a problem is actually a true symptom or maybe a side effect. In fact, when you start adding lots of medicines, this is true of adults too, it's not unusual that side effects get confused with the illness itself and medications get added to treat what is actually a side effect. For example, Stimulants can cause anxiety. That's a common side effect, which can look like the restlessness that's part of ADHD. If the doctor isn't careful, another medicine, maybe a low dose of an antipsychotic, might be added to treat the anxiety that actually could have better been treated by dropping the dose of the stimulant or switching to another one. So, with all that in mind, like I said, these should be golden rules. Start with only one medicine before adding any more. Start with a low dose amount of medicine and carefully raise the dose if needed. These are framed as if we're talking to the doctor, but keep these in mind for yourself. Only change one medicine at a time. That's a really important one. I learned in my residency when I didn't do this once, and it didn't go well, and I couldn't figure out what was going on. I still remember. And stop a medicine that isn't working before trying a different medicine. Now, I'm not saying that always, every time, only one medicine should be started at a time. Everything in medicine has an exception. Every rule has an exception. But these are something that the vast majority of the time, I think, are really good rules that keep doctors, patients, families out of trouble.
Dr. Keats,
Yeah.
Keats, I just want to, one of our participants wanted to make sure that you knew that there are some adoptive parents who are listening, and
I'm sorry.
have the ability to make those decisions, even though we've tailored this to foster care.
Yeah.
Right. And then I also wanted to make sure that I read into the record of this recording that there actually is in the Child Services Manual in 13.8.1, there is a listing about the consent for medical treatment for children in custody. And the primary person who can make that decision is the birth parent. But when the agency cannot reach the birth parent, then the agency usually has an order from the court allowing them to make blanket authority decisions. And in the case of minor types of medical treatment, the foster parent can usually get approval from the agency to go ahead and approve minor or routine types of medical care. Like maybe they have to go to the doctor every 3 weeks or something for treatment of some illness or something. And if it's a minor issue, that the foster parent can go ahead and approve that with the consent of the worker without having to go every time they're going to go to the doctor. So there actually is a section of the manual that addresses that for the foster parents who are listening.
So do you have a sense from that, Kate, or if anyone else on the phone is knowledgeable about this, starting a psychiatric medication as an outpatient?
That's going to require the consent of the local agency.
Okay. All right.
Agency with the custody, and they will have to get consent from the parent unless they have blanket authority from the courts.
Okay.
Okay.
And by the way, so please, adoptive assistance parents out there, sorry I didn't mention you previously. Everything I say is obviously equally applicable to being in that situation. Hopefully your foster child or adoptive assistant child, I guess I'll use these interchangeably, should be addressing these questions on this slide without you even having to ask. So these are more sort of backup questions you should ask if the doctor hasn't gotten to them. I'm just going to go through them really quick. What treatment do you think would be best for this child, my child? Are there any other treatment options? What are the results that can be expected from the treatment? What are the possible benefits and risks of treatment? As we talked about earlier, what are the risks of no treatment? If you think my child needs a medicine, which one? Mostly doctors are pretty straightforward about that. Are there any non-medicine treatments we could try before or along with the medicine? That's a really important one. What are the possible side effects? Of course, any other possible serious effects to watch for? I would add something helpful along the lines of what are the results you expect for treatment? We sometimes talk about target symptoms for psychiatric medications, meaning what are those behaviors or psychological experiences like anxiety that ought to be impacted by the treatment, ought to change. And you presumably would be looking to see if the medication or the treatment's helping with that. An example of this might be the doctor says, this medicine is to treat your child's depression, and you should notice that they are getting better in the next few weeks. And of course, you might wonder, well, what does better mean? What can this medicine do and what can't it do? So you might want to ask the doctor, Doctor, can you tell us some specific things to look for or target symptoms to know if the medicine is working? And hopefully the doctor could answer something like this. You told me your child has trouble with staying asleep and their appetite is off, and they used to love to play basketball, but now it's hard to get them to even go outside. So I'd expect to see their sleep start to improve, their appetite return to normal, and they would start doing things again they used to enjoy, like picking up the basketball. And then you might say, when should we begin to see this? And because it's an antidepressant, the answer is probably going to be, well, probably going to take at least 2 weeks, maybe even 3 or 4. If you don't know these things, it's very difficult to know what to expect and to know if the medicine is working or not. And at the end of the day, it's going to be, unless you have an older or more articulate kid, it's going to be up to you when you go back to the doctor. The doctor's going to say, how's Jimmy doing? Up to you to report in. So I think it's really important to have these kind of more specific conversations. And this is really a continuation of the same, hopefully your doctor will tell you these things, but if they don't, please ask them, what should I do if a serious side effect appears? Do I call you? Do I call the office? Do I go to the ED? Do I use the medicine you said to use if that side effect happened? We talked about the importance, stimulants for ADHD begin to work in days. Actually, sometimes you can see it change in hours. But antidepressants could be weeks. So how long will it take for the treatment to start working? We've talked about trying to get more specific around how will we know if the treatment's working. What should you do if the symptoms don't get better or, and this can happen sometimes, they get worse. So for example, you may know a few years back, there was a lot of controversy about using antidepressants in kids because there was some evidence that in some of the trials where the drugs were being tested, that kids that had suicidal thoughts, the suicidal thoughts intensified on the antidepressant. So if your kid's being treated for depression, doctors prescribing an antidepressant, they should say something about that to you. It's not likely, it's not common, but it can happen. It's been reported. So, and then what should you do if that happens? Of course, they should be telling you when they want to see your foster child back. But and is there anything else that I can do to help? Often there are things you can read up on, support groups, stuff like that. Follow-up care. Once again, no absolute rules in medicine, but if your child has a significant enough psychiatric issue to need a medication, they should be being seen no less, and in most instances much more often, than every 3 months. Every 3 months is sort of the, how are they doing? They're doing much better. They haven't any side effects, a little dry mouth, otherwise everything's fine. How they're going to school, their grades are better, any more acting out? No. Well, last visit was a month ago. Let's see if we can go out to 2 months, maybe 3 months. But that's assuming things are going well. So obviously at a checkup, the doctor should be checking your child's symptoms, see how the treatment's working. Is it having the desired effect? Is it improving the target symptoms? Obviously side effects, you would want to make a note of those and report them. Sometimes the doctors will say, are they having any sedation? Do they seem like they're having trouble sleeping? How has it affected their appetite? But they may not ask you those things. And if you notice those things, you should report them. We talked about, suicidal thoughts. I know that's often a sensitive topic we can talk more about in the Q&A. Really, doctors should be checking your child's weight, height, and blood pressure anyway, but it's especially important if your child is taking an antipsychotic medication, because those medicines, and some of them do that more than others, can cause increased appetite, increased weight gain, and even sometimes elevate blood sugar and cholesterol. And this is pretty common. And something that if it is detected is a reason to potentially change the medicine, because this is, you don't want your child going into their future with problems with overweight or risking high blood pressure and stuff like that. Just going to finish up here with a word about the FDA. You may have heard when it comes to psychiatric drugs that sometimes people talk about an FDA-approved use of the drug or an off-label use of the drug. So we'll talk a little bit about what does that really mean. Because with kids, there's a lot of off-label use. So the FDA, just to review, Food and Drug Administration, it's a federal organization that carefully reviews drugs and ensures they work and are safe for use. Ensures that the approved drug, label, or package insert is accurate, and limits the drug company's sales approach or marketing to include only the approved information. But the FDA does not control how doctors and other healthcare experts prescribe the medications. To get an indication or a label, the FDA has to approve a medication for a certain type of problem that the drug company needs in order to get it approved for that, to submit large clinical trials. If the FDA finds that the study proves the drug does what the company says it does, they give it an approval for a specific purpose or indication. Many psychiatric drugs don't have FDA approval for use in children, but are widely used in children anyway. This is called off-label use because the FDA hasn't labeled that drug for use in kids. Often the drug has been approved for use in adults, and there are some studies that may show it works in kids, but the drug company has decided it's not profitable to do the studies that prove that it would work in kids. And especially for psychiatric drugs, it can be more difficult to prove that they work in children.
Dr. Keats?
Yeah, go ahead.
A clarification question came in.
Mm-hmm.
How would a foster parent or adoptive parent know whether or not a medication that's being proposed for a child had actually been approved by the FDA for use in children? Is that a question?
Great question. Yes, the first thing to do is to ask the doctor. The doctor should tell you, I'm stealing my own thunder from the next slide, but should tell you that now this is off-label. The FDA hasn't approved this drug for this use, but I'm going to tell you why I think it's a good thing. There may be studies that show that it works, or it may work in adults for the same thing. So just because a drug isn't approved for use in kids doesn't mean it shouldn't be used. But you should still ask if the drug is FDA approved for the reason the doctor is prescribing, and if they say no, ask them how they know it's still okay to use it. They should be able to give you a clear explanation. There are also a zillion websites. Drugs.com is one that comes to mind that I think is good, that you can go on and see if the drug is indicated for that purpose by the FDA. But I do want to send the message, especially in kids, not just with psychiatric drugs, but a lot of other pediatric drugs. The FDA has not approved them for that use, but there is a lot of other evidence that they work. Okay, I took longer than I hoped, so let's stop and let's move on to discussion, which we really look forward to.
Great, thank you. We've got a number of questions. I'm going to start with one that comes in from Candace Davis, because I think maybe our case management people might be able to help with this question. Is there a way to get a referral list of psychiatrists within a vicinity, such as Richmond, Virginia's Tri-City area, about psychiatrists who are taking kids? Because oftentimes foster parents have to deal with wait lists and are trying to figure out how they're going to get the child taken care of when the doctor they've been told to go to has a long wait list, especially for Medicaid children.
Sure, I can. This is Ina Tomka. I can weigh in on this question. I was going actually just to do a little brief overview as what we do as behavioral health case managers, but that's one of the things we see a lot and one of our one of the things we try to assist foster care parents, adoptive parents, and social workers with is identifying providers in network. So we do have, a way to identify providers that are close to where the member resides. We have different ranges. I mean, within 10 miles, 25 miles, depending on, the situation and the locality. And so, that's definitely something that we can assist with. Absolutely. We may not be able to know exactly what the wait list is for a particular provider, but we call providers all the time and assist families in figuring out, if that provider is a valid option or we have to move on and find someone else.
Okay, just to clarify, so if a family is saying, if they're finding out that there's too long of a wait for the person that they have been told to take the child to, how would they know to reach you or another case manager to say, is there another doctor who will take the Medicaid card who could provide this service? Would that be something on the Medicaid card that tells them who to call? How do they reach you?
I think they would, they could call member services. Okay. It's a number on the back of the card and ask for, a behavioral health case manager because they have a behavioral health question.
Okay.
They should be directed to the correct person. We have a special team that actually is responsible for triaging calls to the most appropriate case manager. And so, we get calls from all over, parents, guardians, DSS workers, and, we're able to get them into the appropriate channels and answer those questions.
All right. So in summary, they call the member services number on their card and they ask to speak to the behavioral health services case manager.
Exactly.
Okay.
And that's the same number that's up on the screen right now.
Okay. Perfect. Thank you. And now we've got some more questions. One of our questions is, does anyone have experience with a functional MRI before starting stronger psychotropic medications?
I can try to answer that. My understanding of the current state of the art using functional MRIs is that it is not ready for prime time as a way to determine whether or not certain medication should be used. It's primarily still a research tool, a clinical research tool, at least as regards making decisions about what medications to use.
Okay.
If that was the question.
Yes, I think that's it.
Yeah.
All right. Next question. With the overlap of symptoms in conditions such as ADHD, autism spectrum disorder, FASD, I'm not going to say this right, encephalopathy, developmental trauma, etc., how can any one doctor, social worker, or school division be able to say the child has only this disorder or that disorder? Seems to be too much guessing.
Well, I don't know that there's definitely guessing going on out there, I'm sure. Mm-hmm. But I mean, that is the task of generally the primary physician, whether it's a psychiatrist, a pediatrician, a family doctor, a specialist treating the child. All those diagnostic categories have characteristic signs, symptoms, course, test results, and so on. I'm not saying it's easy to differentiate them all, and they do have areas of overlap. And sometimes doctors do the best they can and get it wrong and have to change the diagnosis. That's not uncommon. But I wouldn't frame it up as an impossible task, especially, but it takes time. Psychiatric diagnoses often cannot be made in a single visit or from a single source of information. And even ADHD, it's really should not be diagnosed unless you have a very solid history from a single visit. So even something that straightforward I don't know if that answers the question. I don't have a, I mean, I empathize with the complexity of it.
And I think that one of the things that you're saying is that not only do you look at current behaviors in making a diagnostic decision, but you're looking at a history and what have been the ups and downs or the cycle of the behavior.
Right. There is virtually no psychiatric diagnosis that can be made cross-sectionally. That is to say, tell me how your child did in the last 48 hours.
Right.
You have to get a longitudinal history.
Right. Okay. Now, next question. I have a question about the long-term effects of psychotropic medications. I work in mental health, and one of the primary things that companies are advocating for is for children to be put on medication.
It's awfully, it's certainly a legitimate concern. It's very broad, because it depends on the drug, it depends on the condition, it depends on the age of the patient. When it comes to ADHD and stimulants, we have something like 60 years of experience, and literally millions of people, children primarily, that have been treated. That's reassuring. When it comes to much younger kids or exposure to the fetus in utero, then obviously it's harder to say for sure. And there's, people talk about behavioral teratogenesis, that is to say, not physical malformations, but impact on the developing brain. I know that question, I think, might have come from someone else as well. There are studies, and there are studies that have gone out for years looking at psychiatric medications were started 3-year-olds, 5-year-olds. Generally, but this is a huge generalization, the results are reassuring, but it's very hard to prove something never happens. And so it sounds maybe not very scientific, but we do the best we can with what we have until we know that something is definitively proven to be either ineffective or harmful. My read on, and it's huge generalization, most of the commonly used drugs, and the longer they've been around, the more reassuring it is that these things have not manifested, is generally encouraging, but I can't remove the concern.
Okay. And this question may be more related to what Ina and Jamie do. One of the things that typically comes up in the area of foster care is the fact that children often get moved from place to place, and foster parents don't always have access to the previous medications that have been tried, what all has been tried on the child, what the child currently is on is usually given to them, but they don't know when they go to a new doctor or when they go to the next doctor who may try to put them on something else, but there may have been a history of having a bad reaction to that medication or something else. Families are wondering, who can we turn to find out whether or not the children are actually have already had these medications, already have a history with this medication, and that so they can ask those questions. They don't really know where to go for that information.
So this is Ina Tomka, and I guess I can try to answer this question to the best of my ability. So, as far as Anthem is concerned, we do have some ability to look at medical records, things like pharmacy claims and inpatient admissions, which do have some information about the medications that were prescribed throughout the admission and maybe on discharge. We can see certain information through claims, like what type of outpatient services the member may have received, such as outpatient counseling, psychotherapy, those type of services, how frequently they've seen a psychiatrist or a primary care doctor. However, we are limited to the time frame when the member was actually covered by our plan.
Right.
So it just depends, if the member was on the plan for 3 years, we can probably access some information and share that information. But if there was history that took place before they came on the plan, then of course we wouldn't have access to that.
So, in this particular kind of situation, if a family gets a new placement and they don't have any medical records about what's worked and what hasn't worked with the child, as long as that child has been in the Anthem program, they may be able to call member services, ask for a behavioral health specialist who may be able to go back and take a look at the information. And
right. We could pull up some information. It's difficult to say, what the side effects were unless that's clearly indicated. But we could see what medications have been tried.
Okay.
I would just add, sometimes it's very helpful. So, for example, if, we're told, or the family member are told that, the patient took such and such a drug and it didn't help, and then we go into the system and find out, well, there's no prescription fill. It was never filled.
Mm-hmm.
Well, then we know it's never been tried.
Right.
Even if there was, information that it was given, it might have been handed to the parents,
Mm-hmm.
the biological parents, but they never filled it. So sometimes it's very helpful.
Okay. So that would be the member services phone number, ask for behavioral health specialists, and they may be able to help guide you through what may or may not have been tried in the past.
Correct.
Okay, thank you. The next question that we have on the screen is, are there any recommendations for anxiety related to ADS?
I'm not sure what ADS means here.
I'm really glad you said that, because I thought, is that alcohol dependence syndrome? I'm not sure what ADS is. Ms. Erm, could you please type in what you mean by ADS? I'll wait to see what your response is. In the meantime, I'll go on to the next question.
All right.
We are hearing a lot about FASD or ND-PAE, etc. Families struggle to get diagnoses, and even if they do, meds are really tricky. Where are the case managers at Anthem advising families about where in Virginia to go for diagnoses and for treatment, including med management? Most of the families up in Northern Virginia seem to go to Maryland.
I'm sorry, is the question about where to get medication management services for?
Where are you guys advising families in their behavioral health if they're dealing with FASD or ND-PAE? Where are you advising families to go to get help with diagnosis and treatment, including the med management? Do you have any specialists that you're advising families to use?
And you mean FASD, fetal alcohol syndrome?
Yes. Mm-hmm.
To be honest with you, we would just try, like I said, a similar way to go about just channeling providers in our system. Psychiatrists, neurobehavioral specialists, maybe psychologists that specialize in fetal alcohol syndrome disorders, and we would go from there. We would we would assist in pulling out that list and then contacting the providers, and we would just have to, in the area where the member resides, and see if they, if they have openings and if they provide the type of service.
So that might be something that you would be able to see in your screen that would tell you whether or not a provider specializes in that area.
I think it's more that we would call a provider and ask that specific question. I don't think that we have that level of detail.
Okay.
It's coming, but not yet.
Okay. All right. And then I think that one of the things, Kelly, I'm sure you asked this question. I'm sure you already are aware of the organization right there in Northern Virginia who provides consultation on the FASD. They have a national organization in Washington, D.C., but I think there also is an organization in Ashburn or somewhere around in there. But you're probably already aware of that, Kelly. All right. Could the current foster parent be able to access the Anthem's past pharmacy records, or only the social workers? So if a family called you and said, please help me find out whether or not this medication's been tried, or if this is the right thing for this child, would you be able to talk to the foster parent, or would you be required to talk to the social worker?
Yes, behavioral health case managers can share information equally with the foster parent as well as the social worker.
Great, thank you. And Ms. has said, sorry, autism spectrum disorder is what she was referring to. So
okay.
Recommendation for anxiety related to autism spectrum disorders. It's ASD, not the ADS, which is what's typed.
Okay,
She says
all right.
something about that.
I'm not an expert in autism spectrum disorders. I am not aware. I mean, sometimes there are behaviors that are obsessive compulsive disorder, like the rigidity, the need for sameness, ritualistic behavior and stuff, that has sometimes responded to medicines used for OCD, like SSRIs, like Prozac, like Celexa, and so on. But I guess the short answer is nothing that's surefire. There's some things that have, some studies here and there that are worth trying. That would be one class of drugs.
Which would be what?
The SSRIs.
Oh, okay.
Which are generally good for a number of types of anxiety, panic disorder, obsessive compulsive disorder, to some extent generalized anxiety disorder. Obviously, we're talking ASD now, so it's not exactly the same thing. But these syndromes overlap. So often that can be tried.
Okay. All right, folks, I have come to the end of the questions that you have sent to me. Does anyone want to type any additional questions before we end the webinar? I think one of the things, while we're waiting to see if anybody has any other questions, that I would like to point out is that there's been a lot of work going on in Virginia around the issue of medical and behavioral health care for children in foster care and children who have been in foster care, which would include the kids who have been adopted or have gone into kinship care. There is a work being done at the state level, the 3-branch management, who have been looking at all the medical services that are needed by children, including behavioral health. And in my experience from coming from the University of Illinois, Chicago, I was actually responsible for the program that was led by a psychiatrist, where all the social workers, every time a child was put on a psychotropic medication, that had to be called into a psychiatrist at the University of Illinois, Chicago, to review that medication and to make determination it was satisfactory for that child to be on that medication. There are a lot of programs that are coming up like that in states, and I wouldn't be surprised to see something like that coming up in Virginia. Not necessarily the same as the universities, but Virginia's own variation on how to make sure that children aren't being put on multiple psychotropic medications or having medications changed too frequently and then going back and forth between meds. So I think you can expect to start seeing that at some time. There's been a lot of work being done in the 3-branch process of Medicaid working with social services and the CSA office and others to try to look at how to better manage psychotropic medications. I think in closing, Dr. Keats, if you could explain a little bit to families about what doctors mean and what would the implications be of what we call polypharmacy. Can you talk a little bit about what that is and how families can look for that and be aware of that to be aware?
Yeah. I mean, polypharmacy literally just means many drugs.
Mm-hmm.
And it's not necessarily bad. And people sometimes distinguish rational polypharmacy, where the medications typically have been added stepwise, and one is continued only if it shows signs that it was of some benefit before another one was added, as opposed to irrational polypharmacy, which is kind of violates the rules that we looked at on that slide, student. 2 drugs at the same time, changing more than 2 drugs at the same time, using one very common example that always raises red flags. I'm not saying it's always wrong, but is 2 drugs or more from the same class. So 2 antidepressants, 2 antipsychotics, 2 stimulants. There's not a lot of evidence to support doing that. And I know there have been a lot of initiatives. Some companies have used a threshold of 4 or more medications for a child as being a red flag. It's just hard. It's hard to generalize and say this is good polypharmacy, this is bad polypharmacy, without going through the particulars of the individual case. But it is certainly, when you look at large populations of foster care children in Medicaid and state Medicaid, the rates of polypharmacy are very large and much larger than they are for other populations. And while it's true that foster kids are at greater risk, the general belief is that it doesn't justify the amount of prescribing of psychiatric medication. I don't know if that helps or not, but that's certainly what's meant by polypharmacy.
Right. And I think part of the concern that families have, which is similar to another question that has come up here, is that oftentimes, because the children have been moved so many times, they'll have gone from doctor to doctor, and it's a layering of the medications.
Yes.
And the families get really worried about what is the process that they should engage in with this layering of medications, worried that maybe it's too many meds because they've gone from place to place to place. And how can they work with doctors to say, you know, can we start taking them off of some things and then try to reboot, if you will?
I think the word that comes to my mind, and it's not always easy to do, is advocacy. There, for anyone's right to be worried about the layering on, unfortunately, busy physicians, it's easier to add a new medication than to subtract an old one, because you're never exactly sure, was the old one making a difference or not, and what if I stop it and things get worse? But there are ways to find that out. You could request the records from the prior prescriber. You can ask. You can ask if there was continuity across prescribers with the same foster care parents. You can ask them, how did they do on this medicine? Did it make a difference? Did it make a big difference? If the answer is, probably not, before you layer on the next one, it might be better to stop the first one. But because of the press, I'm not going to make apologies for physicians, but you know, the average medical visit in primary care is 6 or 7 minutes. Frankly, it's hard to do justice to sometimes the complexity of these cases in that amount of time, which means that we as parents or foster care parents are on point to say, well, wait a minute, why are you doing that? And that's what I hope to do with some of these questions. Kate, do people get the PDF copies of the presentation?
Yeah, well, there's going to, we put it on to our YouTube channel and on our website, there will actually be a link to the PowerPoint. So if they just want to look at the PowerPoint and not go through the whole webinar, they'll be able to do that.
I almost feel like we should try to call out the most important questions from those slides, but I think that you have an obligation and a right to say, why are you doing this? Why do you think it'll work? What makes you think it's better than the other thing?
Right.
And if you don't get a good, solid answer, to go, you know what, I might need to talk to social worker, not really comfortable with that. Starting that new medicine. You should feel that it makes sense, the explanation.
Thank you, Dr. Keats. Are there any other questions that anyone else has? I've come to the end of the questions that I have up here. Oh, okay, so I have one. So what is a parent to do if the child has disorders that call for both a stimulant and a depressant medication, a double-edged sword, if we do and if we don't? Very frustrating.
Well, children with ADHD have an elevated risk of having depression, and it's not uncommon or necessarily a problem to use a stimulant and an antidepressant. Sometimes it's not always easy to tell where one disorder stops. Every single symptom in ADHD by itself is something we all experience. Periods of inattention, distractibility, restlessness, drivenness. It has to do with how extensive and how severe. And people who are depressed are inattentive. They have trouble concentrating. So not always easy to disentangle the two. Sometimes you start with one medicine, see if it resolves it before you add the other. But if there's evidence of both disorders, then it can be entirely appropriate to use an antidepressant and a stimulant.
I think the question I would have for you is specifically the way that this person has written it. I just want to make sure that I am very clear. They've actually said their concern is about using a stimulant and a depressant.
Oh, I don't know what that means.
I wasn't sure. I thought maybe that was a term that you would know.
No, I'm not sure what they mean by that.
Maybe they're talking about a medication that would slow the child down rather than speed them up. Cindy, if you can provide us any further information about your question, just want to make sure we get it answered. Are there some medications that would be medications, I don't know what your terminology would be, Dr. Keats, about slowing down the system? What kind of medication that would be?
Yeah, I mean, if you were, a lot of psychiatric medications, at least initially, are sedating on some level. They slow people down in a very general way.
Maybe like an anxiety medication and a stimulant. Would that be what Cindy means?
That would generally not be appropriate. Yeah. Especially since older kids with ADHD are at greater risk for having substance abuse problems. So
mixing a stimulant with an anti-anxiety medication might not be such a great idea.
Generally not. Like I said, it's hard in a vacuum.
Right.
To talk about
Sure.
There was more specificity, maybe I could respond better.
Okay. She's saying example, Concerta and Risperidol.
Oh, okay. That is, that's commonly done. There's a very, and kind of beyond the scope of what we have time for tonight, a lot of controversy about the use of antipsychotics in children off-label to treat behavioral disturbances. It's the area that probably is the most concerning because it can be helpful, but it has to be done very cautiously, and it is never should be a sole treatment. If a child is ill enough to require an antipsychotic for any reason, they should also be getting some form of counseling. I think that's should be a general rule, because there is a tendency to use antipsychotics as to, so quote, control behavior, when in fact that behavior may be a reaction to trauma, environmental changes and stressors, and those should not be treated with they can't be treated with medication. They have to be treated with other modalities.
Great. We have a final question, Dr. Keats. It's about the symptoms of ADHD and anxiety are so similar. How is there a differential diagnosis made?
A lot of it has to do with subjectivity. So people who are anxious, even children, will tell you it's sort of the difference between fear and distractibility, hyperactivity. Most kids with ADHD are not fearful, not excessively worried. They don't think something terrible is about to happen. They're not worried that if their mother goes out of the house, she'll be killed instantly. You have to kind of look at the mental content to some extent. Also, kids with anxiety disorders are typically not impulsive. They are not risk takers as often kids with ADHD are, but to make life more complicated, you can have both. You can have ADHD and an anxiety disorder. But one should not really be confused for the other. There are ways to distinguish them.
Okay. And I guess we do have one final one. This person would like to know how to gauge success and how long to experiment with medications before deciding that they aren't going to have an impact.
Well, as we said earlier, it depends partly on the medication.
Right.
So, you know, you could be sure I would say within a matter of weeks to a month that an ADHD medication, a stimulant, is going to work or not. You can start it at a lower dose. If it doesn't have any benefit, increase it. If it still shows no benefit, it probably should be stopped. There's no absolute threshold for the amount, you know, but the general rule of thumb is if you see no benefit at a lower dose and you keep pushing it, you're not going to see further benefit at a higher dose. On the other hand, if it's an antidepressant, as we were saying, you're going to have to wait better part of a month to see if it was effective or not. But I think the point that the person asked the question, I'm sure, is very concerned, as we all ought to be, that if a medicine, every medication is a trial. Every use of every medication, not just psychiatric drugs, is an experiment to see if it's going to work or not. And if it doesn't, then the experiment failed and it should be stopped. The problem is often that and this is what part of what leads to the layering, is the target symptoms weren't made clear enough initially. The time frame wasn't made clear enough. The feedback wasn't obtained. There wasn't a clear, lot of rating scales can often be used to determine whether there are rating scales for every single psychiatric disorder the medication is helping or not. If there's little or no evidence that it helped, it should be stopped. That's one of the few things I can say unequivocally. The problem is making that assessment, but as a rule, that's probably 100% true. The medicine didn't work, it should be stopped.
Okay.
Yeah.
All right. So all of you that are still on the call, I believe I've handled everybody's questions. If you have one last question, raise your hand. Otherwise, we are going to call it a night. All right. I don't see any more hands going up. Dr. Keats, Jamie, Ina, it's been great having you. We sincerely appreciate the time you have taken to be with us tonight. All of our viewers have indicated it was a great webinar and they really appreciated it.
Oh, good.
So we really are grateful to the time that you took to put this together and to also be on the call with us and answer a lot of, I know, very complicated questions that can have lots of different answers depending on all of the variables. So we appreciate you very much.
Well, we hope it was helpful and appreciate everything that the parents on the phone do.
Absolutely. It was great to be here, and thank you very much for having us.
Thank you.
Yes, thank you.
Thanks. Have a nice evening, everyone.
Have a good night.
Bye-bye.
Bye-bye.
Bye-bye.